Pleasure to be here today with you. I would like to thank the organization for the very kind invitation. Already yesterday evening we had a lovely meal together with the committee. It was really, really nice. So thank you for that. Today I will discuss about one of my big passions actually, and that is infection prevention and control in low and mid-income countries. The challenges, but the beauty of it as well. And I hope that actually after today you will, what you take home is that actually we have to learn from each other, from high resource settings to low resource settings and the other way around. So just a couple of disclaimers. So as Jimmy said, I'm a still consultant for MSF, about 7 years now, and I occasionally do work for WHO as well. Just everything I state is not a statement from these two organizations. I just want to lay this out because that's always kind of an issue. And this is my beautiful hospital, which I will discuss today as well. A new main building, the Radboud University Hospital in the Netherlands, where quite of the interventions that we came up with actually are implemented, and actually can go to low and middle-income countries as well. But my African story actually started here already, actually quite a while now, so 23 years ago. As a medical student actually, I raised a NGO together with a friend of mine, and we've set up a healthcare center and the ambulance network. And I wasn't even a medical doctor at that time. I just finished my first 4 years, and I did my internship afterwards, and was really hooked on infectious diseases. And then in the Netherlands you can do 3 career paths: ID physician, microbiology, or tropical medicine. Tropical medicine, I thought, well, you know, it's very nice now, but what's the long-term perspective? The ID was really not my cup of tea as well, so I really decided to go for clinical microbiology. And fortunately, I've been able to do this ever since. So last year I became a professor in the University of Lagos as well, in Nigeria, and that really took it to the next level, because we will discuss the challenges in mega cities like this. Over 24 million people only in Lagos, with all the problems that they have there. So why infection prevention and control? So for me, it's really about the gram-negatives mainly in low and mid-income countries, with a high increase in carbapenemases and ESBLs, and then with limited resources where they actually have solutions for these bacteria. And this is an issue in high resource settings, obviously, but in low and mid-income countries is even more important. And what you can see in Europe is actually that we see already within Europe, you see geographically differences, right? So you have got the Nordic countries, UK included, which are doing fairly well. And the more south you get to the Mediterranean, the more the pleasant the weather is actually, the higher the amounts of ESBLs and carbapenemases you have. So in Greece already, there's a very, very high incidence of ESBLs and carbapenemases. And as we know, travel is a high risk. So if you have like travelers coming back only from a holiday, have a 30% risk of picking up these resistance genes. So we are very global nowadays. We travel all around. So this is affecting high resource settings as well. This is a beautiful study done by 2 colleagues and friends, published in The Lancet. And what they did is a multi-country evaluation panorama study, it was called, by Andrew. And Andrew is working in Australia, and Kalisvar is working in Singapore. And what they did, they mapped, so it's from different continents. It's from South America, Africa, Nigeria and Ghana was included, Asia countries, and they mapped ESBLs and carbapenemases. And what they did, quite, I think, very straightforward, nice study, they looked at bloodstream infections. So they included all bloodstream infections, and then they differentiated between carbapenemase resistant bloodstream infections and carbapenemase susceptible ones, right? And what you can see nicely on the map on the right is if you look at the length of stay and look at the between brackets, it's actually in weeks. So time since admission in weeks. So this is, it goes up to 6 weeks. And what you can see is that in red, the carbapenemase resistant Enterobacteriaceae, they are the patients that are admitted longest in those hospitals. So that really makes you think that in low and middle income countries, as in high income countries, but in low middle income countries, the biggest risk actually is for those patients that are admitted for long periods of time. And this is actually the reason why we have to focus in those countries really on IPC in the healthcare facilities. So in this talk, I would like to focus on 5 main areas. First of all, the built environment, which is really one of my really big passions. So how to design a hospital. I know I'm in contact with Mike Weinbrand as well, and I know he told me that actually within the UK you're going to build a lot of new facilities as well. At least that's what I got, that's the idea. It's really quite useful to think upfront which type of strategy, which type of rooms you want in your hospital, because they will be there for 20, 30, 40 years. So there's not that much evidence surrounding the built environment. But I will show you pictures from all around the world. Then about water. I think water is very, very important in healthcare facilities. I only touched on this briefly today. Then about improving the quality of decontamination. I think that is an exercise that is already difficult in high resource settings, but even more difficult in low and mid-income countries. Then I want to go to the interventions that are possible as well, and the challenges that lay ahead of us. So for me, IPC is really the balance actually between behavior interventions and infrastructure interventions. And in my experience in the hospitals, we've been focusing a lot on the behavior part of it. But that, at least in my experience, is not really sustainable. You have to do it again and again and again. This morning I spoke with one of you about the teaching that we're doing in Médecins Sans Frontières with Doctors Without Borders. There's a very, very high turnover of personnel. Every 3 months there's a completely new set of people working in the healthcare facilities. So if you only teach and you don't change the infrastructure, you have to keep on doing this with high intensity. And infrastructure, we know, is leading actually to hospital-associated infections. So the infrastructure in itself is a risk factor. I've been involved with WHO in the drafting of these documents. So these are the core components of infection prevention and control. 8 core components, and actually the multimodal approach and the hospital built environment were added in the last version of the core components. And what we did is we came up with minimum requirements for low and mid-income countries. And that was actually a very tough thing to do. So already the core components are quite essential, right? That's the whole idea. And then to make a step and say, okay, from these core components, what could we leave behind and even narrow it down further? That's what we try to do with the minimum requirements. And again, there, the built environment came up really, really importantly. And the built environment, to me, and this is just some realization I had of the last 3-4 years, is really about microbiomes from the hospital built environment and from the human perspective, and then the interaction between. And if you think like this about, well, as a clinical microbiologist already, we have we are quite in favor of the bugs. But if you think about this, that every single building is actually a living creature with their own communities, it's a very different way of thinking, right? And then humans are just as a visitor coming into, again, this environment. And then obviously there's an interaction between the two. And I think that interaction, that is really what it's all about. And last week I was in South Africa with Shaheen Mehtar, and actually she said, and we had a very nice discussion at breakfast, and she was saying, Joost, I finally got it after all these years. IPC is just to stop transmission. And that was her realization after, an entire career of IPC. So it's about that interaction. Then talking about the microbiome. So I think this study really, for me, is one of the best studies that's done about microbiomes. If you didn't read it, I would really recommend you to read it. It's done by a group, again, in Singapore, by Callis Farm. And what they did is they did mapping cultural-based mapping and genotypic mapping of the hospital. And Dutch colleagues of mine wrote a nice editorial about it, and this graph is coming from the editorial. And actually what it's stating is that in a hospital room, you have two communities. So one community is related to high-touch surfaces. So these are the beds, the doorknobs, etc. And the other community is of bacteria, is about sinks and water and watery kind of environments. And they call it community A and community B. Those communities of bacteria are very different. Why? One has a very high turnover, so that's the high touch surfaces. The watery environment has a very low turnover. One is very associated with human genes, that's the high touch surfaces again. The other one doesn't. And what is interesting about it is that probably the high touch surfaces, that community is related to ventilation and your ventilation system. But the gram negatives are found on these high touch surfaces as well with genomics. And so what they were able to do, and I was really flabbergasted about this, they were able to show that the genes that they found in this study were related to a patient and outbreaks of Elizabeth Kingier 10 years previous of this study, 10 years on high touch surfaces. Huh? It is really mind-blowing. So the attack rate is really low, but from the environment, from the built environment, you just have occasional introductions of these bacteria. And that's where we have to focus about. And then lower middle-income countries. So just a reality check. I don't know how many of you have traveled or worked in low middle-income countries, but it looks quite different from our own setting. So one of the facilities I'm always interested in is neonatology and neonatology wards. And I was asked by the CDC to join a group funded by the Bill and Melinda Gates Foundation to do an analysis of neonatology units worldwide. And this is the results. So it was a Delphi method, and it's published as well, so you can read about it. But the main categories, actually the risk factors that we came up with, two of them are about cleaning and reprocessing of medical equipment, and the other one is really about the infrastructure in the neonatology wards in low and mid-income countries. So those two are super important, considered by this group of experts globally, to improve quality of care in neonatology wards. Then I start off with a picture. I always try, if I work in a hospital, I try to make some pictures of these wards, just because it gives a really good flavor of what's happening there. This is actually, I think, one of the best neonatology wards I've ever visited. It's in Sweden, Karolinska Institute, and it really resembles everything that can be nice about healthcare, actually. So what you see in this picture is, I think the pointer's working. Yeah. So it's only, there's a neonate over here, here, and here. So this entire facility is only for 4 neonates. And what's even better is that on this side, every single neonate, there's a door, and afterwards there's a family room where father and mother can reside during the entire stay of the neonate in the hospital. And they are taking care of their own child, and they don't have to go through the wards as well. So this is Sweden, right? This is where things are really nicely organized. But I saw this already now 13 years ago when I was visiting the unit, and I thought, okay, I have to come back and come home and really learn from this experience. One of the things I saw at that time was these partitions. So it's an open bay kind of infrastructure, but you have partitions in between. And I thought that is really clever. Because with contact, there's a lot of transmission going on with contact, right, between the incubators. Healthcare workers that just go around, and now they have to go around the partition to go to the next patient. And that's a threshold. And you would do like they've got, I will come back to the sinks, but they will do hand hygiene. So this would be the only thing that they could improve, but I think the fact that you change the infrastructure, to change behavior, I think is very, very clever. So this was my own hospital. I will show you next picture how it looks like now. But already, it's, if I show this to my students in Africa, they would say, wow, this is fantastic. It looks really nice and clean. And so I was really unhappy with this setup. As you can imagine, all the incubators are next to each other. This is without parents, without healthcare workers, but on a normal day, this is like crowded and it's noisy and it was really awful. So this was our own setting at that time. This is Lagos, so where I teach as well. It's quite empty, it's very, very new. This is just issued last year. So they were very proud about this neonatology unit. Already there are a couple of issues. So we have this ventilation that is recirculating. I will discuss a little bit later. I think that's a major issue. So they don't have any partitions in between. They're now already changing it based on the recommendations that we made. So they're already tweaking the environment again. And again, in this picture, there are not so many healthcare workers, but when I saw it, I visited another time, it was very, very crowded. This is Haiti. Already we're stepping down now. This is where I was invited to actually give advice because we had a huge outbreak, neonatology wards, where we had 100% mortality. So all the patients were dying. And we were able actually to, to do the investigation. And what it turned out to be, one of the things is that, as you can see, the incubators are very close next to each other. Again, there's this ventilation where I was making this picture myself and I felt, this is a container hospital, right? So I felt the droplets actually touching me because humidity outside is very high. Temperatures are very high, so there's condensation. And as a clinical microbiologist, I cultured the droplets within the aircon related to the outbreak, as well that the sinks that were in this room were positive as well with the same microorganisms. So based on this, I did a couple of interventions, which helped a lot. We published it, and you can read it up. This is Tanzania, very different setting again. So we're stepping down from, very high resource setting to like low resource setting. But this is happening continuously as well in Africa. So for a couple of things, so one is that the material, right? So we discussed already biofilms on dry inanimate surfaces. This is wood, and it's very difficult to clean and disinfect wood properly. Proximity of the patients is obviously an issue, and just the entire setup. So for me, it's about knowledge transfer. It's about knowledge transfer between low and mid-income countries, between high and low and mid-income countries, and as we are discussing today, between high-income countries. And this is something we really have to step up. So what we did already, so this is the same hospital in Haiti. So what I did is with local materials, we advised to make partitions, like in Karolinska. We took out the sinks in the neonatology, so we went waterless. And we changed the ventilation, and we were able to drive down the mortality very, very significantly. And it's still quite low. This is my new neonatology ward in the Netherlands. So single rooms only. There's no water inside as well. Remote controls, cameras. And so I learned from Karolinska. I think we improved still a little bit. Although the study is ongoing, we discussed yesterday about single rooms versus multiple occupancy rooms. I don't think, well, if you go waterless, I think single rooms are beneficial. If you're not going waterless, single rooms are not adding actually for infection prevention, unfortunately. That's my opinion. Another example where knowledge transfer was very evident for me. I was deployed during the Ebola outbreak, first to Geneva, where I wrote, together with Bernadette Allegranzi, the guidelines for Ebola in 2014. And then I was deployed to Sierra Leone. And there I visited this isolation room. And for me, it was like everybody who was working in a hospital knows an isolation room, right? So you have one empty room, which you enter when you're still clean, you're putting on your gear, you go to your patient, you go out, and you contaminate the anteroom. It didn't make sense to me at all when I saw this. So what they did, very clever, this is really rural Sierra Leone, they've got a clean anteroom, they go to the patient at the back, and then they go out on the other side. I thought, this is it, this should be my new isolation room. So this is a guy who's there in the middle of nowhere, thinking about IPC, and he just understood the mode of transmission, because Ebola is not airborne, it's just contact, so they've got beautiful natural ventilation, as you can see. So what we were doing is developing a new high-level isolation unit on the bottom, and it's now actually in place. So this again is my facility, and this picture is from the patient room. So this is the entrance, where you have a clean anteroom, and then you go out on the other door, which is the dirty one. We used the lines on the floor again, so red is dirty, orange is intermediate, and there green is clean. So simple interventions, but high-tech interventions as well, where we now have a buddy who is continuously looking with cameras and audio with the patient, with the healthcare worker that is taking care of the Ebola patients if they are there. So again, next level. So you can combine these low-key kind of interventions with high resource and high-tech interventions. So that was my first. Then I would like to switch gear a little bit, go to water. I already made a couple of remarks that this is, for me, is really like an interesting topic. I love water and water in healthcare facilities. And I will give a couple of examples where I think it's crucial for you to really to think about. Water has been there for a very, very long time in hospitals. It's just a picture from a leper hospital in Ireland. But why is it a problem? Again, I was struck actually by something completely different when I was reading this paper. And it's about trees. It's a beautiful paper where trees are actually sharing micronutrients with each other. So trees are helping each other out because the roots are interconnected. As I was reading this, I thought, if this is the case, I know quite a few branches, roots within my healthcare facility where the bacteria can share something as well. So immediately, I was thinking about the sewage and all those things. So I thought, this is something I have to further investigate. And one of the first things that came up was actually something quite extraordinary, was an observation from, and I think you're familiar with this story, but it's a story from Hugo Sachs, basically, a colleague of us in Switzerland, and he made observations about Mycobacterium chimera in heater cooler units. And they had a couple of patients that were operated upon, and then with a very long incubation period, they developed severe infections with the Mycobacterium chimera. And as you all know, mycobacteria are heat insensitive, they are chemical insensitive, very difficult to get rid of, they're easy to aerosolize, so it's an ideal bacteria for airborne transmission. And then all of a sudden we had one case. We are the national reference lab for non-tuberculous mycobacteria. And at that time I was responsible for the infection prevention unit. And I had a resident, Jacco van Inge, who's now leading the non-tuberculous mycobacterium lab nationwide. And actually he said, Joost, this is very curious. We have an isolate from Zwolle, which is a city up north in the Netherlands. And that patient has been operated upon with cardiothoracic surgery, and he has a Mycobacterium chimera infection. And I just read this paper from Hugo. I said, this cannot be coincidence. So we investigated. And then we said, okay, we have to scale up. This was during the Ebola outbreak when I was already deployed in Geneva as well. So we had to do 2 outbreaks at the same time. But we said, okay, we have to scale up. So the entire country, all the experts came together, and actually within a couple of days, we were able to get rid of all the heater cooler units in the OR, put them outside. So this is the heater cooler unit for people that are not familiar with it. It's just heating and cooling the system so that during cardiothoracic surgery, the patient has the right temperature of the blood flow. This is outside the OR in my setting. So the tubes are going through the wall into the OR, and this is the oxygenator. And so we were safe because this machine is contaminated. So it was just spreading continuously this Mycobacterium chimera, but it was outside the OR. So our patients were not infected. But we cultured this. We did air samples, samples of the water. There was Legionella as well in this machine in 2 different hospitals. So healthcare workers were exposed. But we were managed to deal with this outbreak in the Netherlands within a week, just to change the setting. At that time, I was invited by the head of CDC to go to Atlanta. I was in Africa meeting with him, talking about Ebola. I said, do you know about the chimera outbreak? He said, chimera outbreak? So they didn't know. So I was invited so I flew to Atlanta to talk about this problem. And even a couple of years later, the FDA had a very thick guidance document how to deal with legislation, but the heat-cool units were still in the OR in the US because they thought it was a high risk to put the tubes through the wall. So it's very interesting how different cultures deal with these type of problems differently. Another story, showers. This actually was a patient, and we published this in JAMA. A patient was colonized and infected, and unfortunately he died with the Pseudomonas, a Vim-positive Pseudomonas. And we don't have a Vim-positive Pseudomonas in my hospital, so this was a red flag immediately. We cultured all the patients. Everybody was negative in the ward. And then we started culturing the environment. And then the shower drains turned up positive. And I still recall quite vividly, I was at that time again with Shaheen Mehta in South Africa. So my IPC nurse called me and said, Joost, the shower drains are positive. I said, well, okay, but what's the mode of transmission? I just don't understand how, can you become infected from this shower drain? So I said, please start doing air samples. So they did air samples, and the air was positive after taking a shower with exactly the same bacteria that are in the shower drain. So what we did is we start mapping all the rooms. So this is a map of the ward, where in orange the positive rooms are located, and in blue the negative rooms are located. So the positive rooms are all interconnected with one sewage system, and the blue ones as well. So for me, at that time, it became clear, like with the trees in the forest, they are interconnected, right? So they just grow from one side to another. And then we did whole genome sequencing, and they were completely the same, air sample included. So we had proven that there was this interaction between the rooms, and that most likely there was airborne transmission through which this patient, because he had thoracic surgery, so he had a huge cavity, became colonized, and from there he had an invasive infection with this Vim-positive Pseudomonas and died. So for me, this learned me one thing, that cleaning and disinfecting of the shower drains is really not easy, and you shouldn't go for it because it grows again, and that's not sustainable at all. And that to come up with solutions is quite difficult. Then Mike Weinren, he's a couple of weeks ago, he sent me this nice picture. It's from colleagues in Heidelberg. I don't know if you read the article. If not, I would recommend reading it. It's a very nice paper. They had this outbreak again with the Enterobacter cloacae, and they were able to trace it back to the shower drains as well. But they came up with a solution. And what they did is they introduced this small, how do they call it in English? Tub. Yeah, it's just a tub that they put inside. So basically they stop the direct interaction of the water with the shower drain, and then the tube itself that is within the tub, they can take out and they can sterilize. And with that, they are now 12 months post-intervention, and they have zero transmission. So I think this is a very nice solution, and I already recommended it last week to my IPC nurses, that we should look into it. We had a different solution. We developed a shower drain that you could, that consists of two parts, where you can take out the top part and clean it manually just more easily than the previous ones. But I think this solution is actually way better than our solution. And this again is about learning from each other, how to deal with it. Then from shower drains to sinks. This was my ICU room prior to the intervention. And as you can see, the sinks were in very close proximity to our computers and to the tables where we were preparing all the central lines, etc. And I had two big outbreaks when I started in 2010. What we had to do actually is had to come up with a solution. And I thought, okay, so how to deal with this? And the sinks, historically, as you all know, are used for hand hygiene. But hand hygiene, if you think about it, was not hand washing, but was hand disinfecting with chlorine disinfectants. And that was obviously seen by Semmelweis. So over time, we switched from disinfection to hand washing. And if you then go back to lower middle income countries again, there's a very nice publication from UNICEF where actually the water at the point of consumption is contaminated in low middle income countries in 70% of the cases. And this is within healthcare facilities as well. So now think again about sinks and the water that you introduce, and for wrong reasons, because you can have a different solution with alcohol-based hand rub, and then immediately it becomes almost like a medical mistake to do this. And the other thing is that water is quite scarce in different parts of the world. So South Africa has huge problems nowadays with water during summer times. And again, because if you visit there, they have got this different periods where you don't have access at all for water. And that's another reason, I think, in low mid-income countries to switch gear and to go to different solutions. So in my case, I was actually going through the literature. Nice papers from England as well, from ALIV, where they showed actually the relation between sinks and the patient's colonization a long time ago. This was in the 70s. And then your famous story about the cholera pump really made me think. I was cycling to work, dealing with this, I always cycle to work. And then when I'm cycling through the forest, I get this nice idea, so I can really recommend doing this for you guys. But I was thinking about the way you dealt with the cholera outbreak and just taking out the pump. So I thought, let's just take out the sink in my ICU. So this was in 2013 that we did this publication and this intervention. So we took out the sink, before-after study, included 1,500 patients before and after. And we were able to show actually a significant reduction in colonization of gram-negatives within my patient population. And it goes up to a 3.6-fold reduction in patients that are admitted in my ICU for more than 10 days. So it's a very significant reduction in colonization. This is just a practical joke because I was doing my rounds and had some residents with me, and I got a phone call, and it was from the BBC, and I really thought people were taking really a piss on me, like, and with the classical English accent, like, can I do an interview with you? And everybody was laughing very hard, but it was seriously. So it was the BBC about this story about the sinks, but it's just something I remember vividly. So this is the 3.6-fold reduction after patients that are admitted for 14 days. And we had published this. It's already 10 years ago, but I have to say that now in Asia and Europe, it's now really picking up in England as well. So especially in the ICUs and neonatology, all the big hospitals are starting to go waterless. So that's very interesting to see. But it takes 10 years after a first experiment. It is included in the WHO guidelines to prevent carbapenemase-resistant bacteria. And there's a small box about the location, which I think is most important. We discussed it yesterday. For me, it's really the proximity from the sink to your patient. And the longer the distance, the better it is. It's not black and white. If you can't get rid of your sink, if you're already able to take it out of the patient zone, you're already in a much better place than if you can't. But we took it out of the patient room entirely in the new facility. And then the thing about sinks is that they're actually not used for hand washing. So this, Amy Mattis called me. She was responsible for a huge facility in the US, and an outbreak, and she called me. She had heard about our experiment. So and I gave her some advice, and we discussed, and it was really interesting. And she did actually the experiment that I should have done. She just put a camera on top of a sink. Very simple, very straightforward, but she got the results that actually sinks are only used in 4% of the cases for hand washing. In all the other cases, it's used for discarding of waste. So what is the real challenge? It's not that we're not using the sinks for hand washing. I think it's about waste management. So I think what we should do is put all our energy in to deal with how do we actually organize waste management in a much better way. So for me, it's very simple. It's hand hygiene, is alcohol-based hand rub. It's very straightforward. Only in very specific situations you should do a hand wash. And it's about discarding of detergents and disinfectants, biological waste, and infusion fluids, including antibiotics. That's what we have to focus on and come up with solutions. And it is very important because the microbiome study that I showed you in the beginning of my talk, actually they showed that there's a lot of cross reactivity between the genes that are responsible for resistance to disinfectants and the ESBLs and carbaphenamases. So already there is resistance to disinfectants on Staphylococcus aureus, on Acinetobacter, because they are interacting. So I think limiting that exposure is like very, very crucial, and there are not so many publications dealing with this. Evidence-based decontamination. This, for me, is a very interesting study. Because there's always this emphasis on hand hygiene. And to my opinion, actually, cleaning and disinfection is maybe even more important. So in this interesting study, they did it the other way around. They had an outbreak, and they didn't start with the improvement of hand hygiene, but they started with the improvement of cleaning and disinfection. And then they saw a stop of the outbreak, of the VRE outbreak, and then an improvement of hand hygiene didn't add anything afterwards. So it's another way of thinking, again, about what we should do more. Then the detection of gram negatives and gram positives. I think this for low middle income countries is very important. And I will show you afterwards this slide. So this is a German, again, a Nordic country where they see that environmental detection is mostly about gram positives. But that has to do with our climate. It's cold, it's dry most of the times, not always here, but humidity is not that high. And then you have a low percentage of gram negatives, right? But then this very nice study in Ghana again, Cape Coast, where they very recently did an environmental study where they were able to show they were sampling obstetrics and gynecology, female medical wards, ER, and they were able actually to show that their swabs were almost 100% positive, but this is without any selective media. But they had culturing as well with vancomycin and with meropenem. And then in more than 50% of the environmental swabs, they were positive with gram negatives, with carbapenemase-resistant gram negatives in that setting for a long period. And if any one of you has visited Cape Town, it's very humid all year round, and it's about between 30 and 35 degrees. So ideal circumstances for gram negatives to survive. So in low middle income countries, very different story. So if you read a paper about these organisms, it's really good to think about where are they coming from. So this is published by Kramer, again a German, and they were able to show that they Enterobacteriaceae can survive for many months already, but that was mainly the gram positives. And so I would like to see this same study done in low and mid-income countries, and then see under experimental settings how long this period actually is. The high-touch surfaces that the Ghanaian publication was really focusing on, I think, is absolutely critical. So this is a typical bed. This is a picture I took in Indonesia, which looks fairly okay. It's a little bit damaged, but not too much. But if you hear again, something that will be touched upon every day, multiple times, it's completely damaged, it's dirty, very difficult to clean. And this is day-to-day reality, right? This is just at the end of the bed where they do the history taking and the registration. Again, wood, all damaged, very difficult to clean and disinfect, right? So again, in low mid-income countries, this is reality. So then we have a couple of ways of monitoring this. Visual inspection, very low sensitivity, adenosine triphosphate, fluorescence markers, and microbiology. We did some studies and published it as well with the correlation between the difference. And I think there's something to say for all of these 4 different categories in low mid-income countries. ATP is very fast, but it's very expensive. Reflective surface marker are only measuring process, right? And culture is difficult if you don't have the money or a lab, actually. But it is interesting to see that if you use these type of markers, you are able to analyze actually the quality of your cleaning and disinfection. And in this case, they were able to show that there's a really difference between cleaning by domestic staff and by clinical supporting staff. Then to switch gear, and I had to mention this because it is a hot topic. We debated it yesterday a little bit over dinner, but reprocessing. So this morning I put in a couple of slides. I thought I have to, start the debate a little bit with this audience. But reprocessing of medical devices that are labeled as single use is really a non-issue, kind of non-issue in high resource settings, although the debate is coming because of sustainability issues. But in low and middle income countries is a very, very different story. So they're doing it all the time on the circumstances that are not really favorable. So there is this is a nice consensus document from India where they have a guidance actually how to do it. And you've got a nice statement that in developing nations of Africa, Asia, Eastern Europe, etc., although reuse is very common, cleaning and sterilization of single-use devices is often performed within the hospital, sometimes in an unregulated manner. This is even written quite politely, right? So it's really unorganized, and if you go through those type of settings, it's really something you don't want to be as a patient. But it happens because they don't have the resources. So again, this is really something to look at. This is a nice statement as well. I always like when the ethical people and professionals are joining the debate, because what we try to do in IPC, with my medical ethical committee, I always try to invite them actually now with these type of conversations, because they have a very different perspective. And this is a nice publication where they say about financial hostage. So they say the stipulation that a single-use device never be reused the healthcare system and society at large in a position of financial hostage to manufacturers. I think it's an interesting statement. And it's something that you have to start thinking about, especially with the prospect of sustainability and climate change as well in high resource settings. The Asian Society actually drafted a very nice guideline that has been and is used in Asia really almost in every single country. Colleagues of us drafted this, and there are nice recommendations, which I think this one is the most important for now. So critical and semi-critical medical equipment devices labeled as single use must not be reprocessed and reused unless, and this is the unless part, the reprocessing is done by licensed reprocessor. So actually they state in this guideline that it is possible to reuse under certain circumstances. And what those circumstances then are is, I think, something we should look into more detail. I've got 50 minutes left, so I will go to a couple of interventions that maybe will be useful as well. So I was triggered by this publication. The reason is that there is transfer from beds to hands in quite a significant amount and percentage, up to 38%. And then actually in a high resource setting, this is my own hospital, we have a bed washing machine. So every single bed after discharge goes through the bed washing machine, is heat disinfected, mechanically cleaned, and comes out really quite clean, I have to say. But there was no data at all. So I was thinking, okay, I have to do a study about this. So we did. So we compared the two, and it was a very significant difference between manual cleaning and mechanical cleaning. While even with the manual cleaning, I did a very powerful training of the people that were doing this cleaning prior to the study. So they were highly, highly trained, best circumstances that you could ever think of about manual cleaning. And even in that setting, they were less efficient than the mechanical cleaning and disinfecting. The training in itself was very successful. We measured this. And this was all still in a high resource setting. So then what I thought is, okay, if this is the case, this is my high resource setting. Again, I want to go down one step to a middle income country. So Shaheen was there in South Africa. I said, Shaheen, can we do a study? Yeah, of course. I've got the best IPC unit of Africa. I said, that's great. So let's go to Stellenbosch, where I was a senior lecturer at that time as well. So we did the comparison between the two. And actually, so this is South Africa. So before and after cleaning, a nice significant reduction. This is actually Holland and South Africa after manual cleaning. So there's no difference whatsoever. So if you do the training properly, you can get the same results with manual cleaning in a mid-income country as you can in a high-resource setting. So that is, again, for me, a very important message. Some things that we came up with, the beds in wards with a very high turnover are high risk to be contaminated. If they are highly contaminated, high risk. And if you do use disinfectants instead of detergents for the cleaning, it's a high risk of being contaminated as well. Another thing that we can introduce as an intervention, this is again my high-level isolation unit, where you can see we now have an interactive touch screen where we can guide actually the healthcare workers through the process of donning and doffing. So it's completely interactive, and it gives you actually all the steps going through the procedure with pictures and text at the same time. I think reminders are super important, but this is again next level. Well, this was when I was deployed in Sierra Leone. This is Kenema Hospital, where I saw a graveyard with all the healthcare workers that passed away, with more than 30 passed away after the Ebola outbreak, where they put actually just the healthcare worker next to the reminders, and that's very powerful as well. But I think in low mid-income countries, these tablets are very cheap. We could introduce them in low and mid-income countries fairly easily. Another thing that we did, so I came up with, within Médecins Sans Frontières, we did, my observation was like, okay, doing the entire exercise of observations, etc., is very time-consuming, measurements, people don't know how to do it. Let's just automate this process. So we came up with an app that is actually, you can do the observations of hand hygiene, it is sent to one central database, the calculations are being done, and then it's being projected in this dashboard that is again visibly in all the healthcare facilities of MSF worldwide. And we publish this as well. And just making life simple for people. I think that is the message, that's the message here. The training, so together with Shaheen we are running this training program. We need volunteers for the sterilization part, so if you, I just wanted to make use of the opportunity. So if anybody is interested in teaching, this is what we're doing. It's online. You don't have to travel to Africa. You can just do it from your own house. And it's really rewarding, I have to say. And so we have, then the students, they are sitting behind our household. You see the chickens walking around, and we're discussing everything. It's so nice, and it's a real community. That's the interesting part of it, even if it's online. Another intervention, infrastructure. This is the Ebola outbreak. the washing of the clothing was done really on suboptimal circumstances, I have to say. But then when the money was pouring in, all of a sudden we had this huge Miele washing machines available in Sierra Leone, middle of nowhere, crazy setting. So my take-home message here is, if we invest proactively a little bit more on infrastructure over the long time, you can do so much for in these settings. So infrastructure. Oh, yeah. Waste management. This is next to an Ebola treating unit. I don't know if you can see the visitor in this picture, but I can zoom in. It's not ideal as well. So waste management is really something in low mid-income countries that we need your experience and advice to improve. Then switching gear again, endoscopes used a lot in low mid-income countries as well in high. This is a study, it's not even published, that we did in my setting, where we used UVC actually for endoscopes without a working channel. It's a multi-center study, and we were able to show that it's actually more effective than a traditional standard endoscope washer disinfector. And it's already on YouTube, you can see that, so you can look it up. And we will publish it soon. Another thing that can go to low mid-income countries, these two guys, they came to me, they were just left university. They said, Joost, can we get your advice? So I gave them advice for this one, and actually the endoscope, that was the idea. They said, can we do something else? I said, well, maybe you can go to endoscopes without a working channel, and that's what they developed. So I'm a little bit to blame for that. But this is something that can go to low mid-income countries. You can put a stethoscope in it, your telephones, and within 25 seconds it's fully disinfected. So we use it within my facility as well, but the price has to go down. Bill and Melinda Gates Foundation is interested, others. So I think this is something that is useful actually in low mid-income countries as well. And then something that is really even quite far away, but I wanted to show you because we are developing this now together with a company from California, UFA it's called, and it's using, in my university hospital we have 8 rooms that are now designed with this, and we're detecting with optical, infrared, all the movements within the room. And it's actually really quite interesting. This is what we're aiming for. So infection control, we can do all kinds of nice things. For patient safety, you can prevent actually patients falling, because if they start moving, you can already put the lights on in the middle of the night, because it's with artificial intelligence, and it's most likely that those patients want to go to the toilet. And then if you put the light on, they're not falling out of your bed anymore. But what I was most interested in is, can we use this? So together with a professor in surgery, Harry Vergoor, where I'm collaborating with, we're actually trying to use this now for IPC. And so we have a mapping of these patient rooms where we can show them where the surfaces have been touched. And you have this very nice maps that are recorded, and you can present it in a dashboard with all the different rooms. So you get a map like this, and then my future, what I want to achieve now is actually, as I told you, the training of your domestic personnel is one of the biggest problems, I think, we're facing of cleaners. What if we don't have to train them anymore, but you can, the cleaner, you can just put on a VR or augmented reality, and they just see which surfaces have been touched, and you can just clean those surfaces. Or even better, if you have a robot in the room continuously, it can go immediately after surfaces have been touched, they can start cleaning. So we're not trying to develop this, and you think maybe this is like science fiction. I don't think so. And in low mid-income countries, when I was working in Ghana 23 years ago, I had to drive with my Land Rover for 3 hours to go to a telephone booth to try to make a call to the Netherlands, which often didn't work. And now, when I visited it, they are paying for on the market with their telephones. So there's a huge leapfrog in low mid-income countries. So I think these type of things will be, probably even in Africa, will be there earlier than we have adopted it in high resource settings. I'm quite sure. To measure it is something else. This is just to share with you from my MSF experience. We tried to develop a stepwise IPC improvement approach, which was quite successful, because my observation was that we have to show improvement in order to keep them enthusiastic. So after we drafted the IPC program, actually we start introducing this, and this is again the setting. Then this is just a picture from Nigeria, from a hospital. This is an isolation room in Nigeria, different setting. But what they do is they do these observations on their tablet. It will be sent to the central database and reported back. So again, the analysis is not being done locally, but it's being done in a centralized, automated manner. And it's very useful because it's very stimulating to see that you're actually increasing, right? And that it's visible for everybody, and you get feedback from others and your colleagues. The biggest challenge, and then I will stop, is actually for me is really about the climate and climate change in low mid-income countries. So this was a piece I wrote in JAMA during the COVID outbreak, and it's about preparedness, critical care that is very, very difficult to organize in low mid-income countries. The minimum IPC requirements that are not met, the climate change that is very evident, the consequences is a huge amount of refugees and in conflict zones. And the media is really taking a big part of this as well, because, mind you, everybody, even if they are living in small huts somewhere in Africa, with the communication nowadays, they know what we are doing. And it's a very different setting, right? So they're not isolated anymore in terms of communication. And urbanization is a huge problem. There will be a doubling of the population in Nigeria in 2050. So 200 million people will be born in addition to the current population. It's a huge problem. With the climate change and the increase of temperature that is now going, emerging pathogens will be there that we have to deal with. And water and just the general things of fresh water, etc. That will be a significant problem in low mid-income countries. They will be affected more than we will in high resource settings. So the biggest problem on health and healthcare will be, in my opinion, about climate change. So air pollution, transportation, clean water, zoonosis, waste management, and resources. That's what we have to focus about. And I think this is just a picture I took in Switzerland. It's a complete opposite, it's where everything is extremely beautiful. So it's all about knowledge transfer, and with that I would like to conclude, and thank you for your attention.
I don't know about the rest of you, but I sat there grimacing, holding my head in my hands, making funny faces and thinking, wow, what a presentation, what a career you've already had, what a career you're going to have in the future. You mentioned knowledge and transfer is so important, and I think you have talked to us today about so many aspects of our own lives, our own careers and our own specialities. And you've put it all together in one presentation, which is absolutely phenomenal, and I've got to thank you for that. And I can see already there's people absolutely dying to ask a few questions in the audience. We don't normally allow questions for the Kelsey, but I know you particularly are keen for that. So, Lucy, would you like to? Pat, just wait for the mic. Just say your name and then.
I'm Joost Hopman. I'm the head of decontamination in Scotland. Thank you for sharing. That brings back my memory. I was born and raised in one of those countries that you mentioned. I remember when I was a child, if I had a fever, the doctor will give me 3 different types of antibiotics. I think the prescribing of antibiotic is an issue. With the training only, it's not sufficient. I think there is other financial aspect as well. Secondly is I also did work placement in one of the hospital as a part of my degree. I've never seen ultrasonic cleaner nor water disinfector. So my question is, how can we help the low and middle income country in terms of providing equipment and maybe consumable. We have a number of equipment that, or devices that no longer used but still perfectly suitable. However, there is hesitant of liability and training and so on. So welcome your feedback. Thank you.
Yeah, I think, well, one is that the materials that are really still in good order, that we come up with the logistics that we can actually indeed send this to these settings where they can use it properly. I think I would be in favor. My only reluctancy would be to introduce things that we don't want, that we want to step away from in our setting. So I think that's the only caveat that I see, is that what you do want is to actually, for them to step over the mistakes that we have been making over the last 10, 20, 30 years and go to the next phase, right, for certain income. But I truly think that in certain circumstances we can actually send material in much better way to low mid-income countries than we're currently doing. Thank you.
Nope. Oh, yeah, it's on now. Hi. Samantha Murray from an Iron Bevan University Health Board in Wales. I'm a senior infection prevention nurse and also decon manager from a clinical aspect. Thank you so much for that. It was amazing. Actually, I've got two questions, but I'll use one. Considering duodenoscopes with regard to ERCP, and we speak about the multi-drug resistant organisms, CRE, CPE, CPO, whatever you want to call them, the latest research is particularly in America, some in Europe as well. What are your thoughts on sterilisation of the duodenoscopes?
Yeah, so I think with the problem, as I showed you, this solution with UV is only for a non-channel, non-working channel endoscopes, right? I think with working channels, it's a very different story. So we have to be very careful to draw any conclusions. And one of the experience I have, at least in low mid-income countries, that quite often they copy-paste things from high-resource settings just to their local context without taking the local context into account. And I think that is actually the biggest risk if you start thinking about making recommendations. You really have to know the local context in order to make a proper recommendation.
Thank you, everybody. Dr. Hopman, thank you very, very much. I'd like to thank David. We're going to